Okay, so most of you have voted. Just sharing the results now. So 50% of you thought the best motivator for you to share your personal health data is to ensure that you receive high quality medical care. All right. So before we start today's seminar, today's talk has been endorsed for one CRCP point, and it's a pleasure to have Maureen Turner with us today. Maureen is the Chief Executive of BioGrid Australia. She has over 10 years of experience handling clinical and administrative data for research purposes, and has expert working knowledge of the legal, ethical, and security requirements for sharing consented and non-consented data between institutions and across jurisdictions for the purposes of medical research. She also has expertise of projects requiring establishment and maintenance of national data sets or data platforms. Maureen holds an MBA from RMIT University and is a fellow of the Institute of Managers and Leaders and a member of the Australian Institute of Company Directors and a member of the Australian Institute of Digital Health. Thanks, Maureen, for coming today to present to us on an overview of BioGrid and how to accelerate medical research through curated clinical data.
Thanks, Dawn, and welcome everyone, and thank you for the opportunity to present. So I thought this was actually quite a nice segue from the last fortnight's presentation on trust and the issues around trust and data. And so I think that the things that we can sort of look at and discuss today will be able to provide at least an option for researchers to be able to utilise a trusted platform. So I'd like to cover today a few areas obviously related to data and data platforms. First of all, just outlining the actual data problem that we face. This is quite common around the world, but in Australia particularly, we have disparate data everywhere, and that's one of the challenges that all researchers face. Some of the key aspects that you need to consider and really have in place for a data sharing framework, and then how BioGrid has been able to provide a solution for that that's really addressing the issues that are at the grassroots level of researchers, clinical researchers that is particularly, and just to provide some case studies of projects that we're involved in, but also some that are really challenging because they're trying to access a lot of data from different jurisdictions around the country, and how we can actually help support researchers through that process. So first of all, the data problem. So you'll all be aware of this. You're all people involved with health data in some way, and you know that it tends to be locked up in different areas. So we have clinical data that in itself is in silos within institutions, particularly in hospitals, let alone across hospitals or jurisdictions. We have government data, which is kept at a government level, which can be really rich and great to get access to, if you can get access to it, but that's the challenge, getting access to it. You have obviously in hospital systems that are providing really valuable information for a particular type of research that you want to do. There's also population health data, and these can be a range of different kinds of registries and longitudinal studies that have been collected over time, but they sit in different places and have different governance frameworks to have access to them. And of course, we have primary care data, which is different to the hospital setting and has been a challenge in Australia to get access to, but that's now starting to improve. And lastly, there's administration kind of data. So those things that really help us to understand the types of admissions that occur, and then the costs that are associated with these, and to be able to use that data for economic aspects of research. So all of these data, if you could get access to all of it at the same time, wouldn't that be wonderful? And it would be really fantastic to be able to do some really great research. But there's challenges with all of this. And a lot of it is to do with governance frameworks and the requirements to be able to access those data. So starting with that as a premise, knowing that with data, we have it everywhere, and there's lots of it. It's collected in different places. It can be difficult to connect to. There's individual privacy issues that you need to consider, and sometimes consent. And then there's also rules around the access to that data. So government data might have different rules for access than what might be for a research group that's collected a longitudinal data set, for example. They'll be different. So how do you manage all of this? And of course, you have to deal with the issue of the volume of the data. Some of this data is really large, there's a lot of it. It's obviously dispersed. You need to be able to, how are you going to connect this data across different data sets to really have meaningful research? And as you know, in Australia, although we do have a unique health identifier, it's not actually captured or utilised uniformly across the health sector in Australia. So there is no one unique identifier for an individual in any of our health data sets in the country. So how can you connect data between these data sets? And then making sure that there is compliance around the individual privacy of data. Now this compliance is obviously we have to meet the requirements of the Privacy Act, but there's also Health Services Acts for public health institutions. And then there's the issues with different legislation requirements between jurisdictions. There are different jurisdictions in Queensland and South Australia, for example, that don't allow health professionals to provide personal identifying information to third parties without consent. And that's different to other jurisdictions. And then understanding the flow of that data between jurisdictions. There's also legal, compliance around that. So, these are complex issues that you have to deal with when you're thinking about bringing data together into a platform and making it available for research. And then the issue of consent. Well, if you had to consent every single piece of data that you have for research, there wouldn't be a lot of research that's done. That's kind of the reality. So how do you navigate these matters? And there are exemptions in the Privacy Act, and the NHMRC guidelines allow getting access to identifiable personal identifying information for the purpose of record matching, for example. But it's navigating and understanding all of these issues to ensure that you are compliant with the way that you're doing research. And then in terms of access, there are many different systems that you have to use to get access to data, as well as the rules that you have to navigate. So we've set the scene. It's challenging. It's difficult. So how can we make things more streamlined to accelerate research for researchers? Process. We also have issues around the process as well. Those different data sets that I was mentioning before and the different custodians of those data sets, there will be different processes that you need to use for applying for that data, different systems. We access, for example, about half a dozen HREC systems to apply for the data linkage ethics that we have around the country. There's not one unique system for the whole country. There's different forms and processes that you need to use in different jurisdictions that are asking the same questions, but they're different applications. There's also the issue of custodian approval. Now, some data sets are managed by a steering committee. Some data sets are an individual. Some are at the hospital level, some are at the academic level. We have different requirements for different custodians. And then, of course, you've got to consider the ethical approval of having access to that data. Project approval. So I've separated those out because BioGrid actually has an ethical approval process in place for the linkage platform, which is separate to the use of that data, which is then the project use. So we have two layers of ethics, which I'll explain later, and that really streamlines the process for researchers and accelerates the process for researchers to access the data and do their research. And then, of course, we have data linkage and data access processes that you need to look at as well. So by ensuring that you have expertise that can support all of these more complex application processes that are required, to ensure that you have collaboration with the custodians that actually have oversight of the data sets, and then complying with all ethical requirements and going through the processes that you need to, and then understanding the methodology of the data linkage that's required, and ensuring that you have the appropriate access to access that data. It's a lot of things that researchers have to do to be able to access data. So how can we streamline this to make it easier and to ensure that we can accelerate that process for researchers, but not compromising any of these matters? So we have time as an issue, and researchers are time poor. We know that, particularly clinical researchers who are also doing clinical work. And of course, all of this, if you're going to actually get resource to do it, it costs money and time. So how can we streamline this for researchers? So a data sharing framework that can address all of these things is of course going to be of great value to researchers and accelerate the process. A legal framework to allow this data sharing would be really useful. An ethical framework for the data sharing would be really useful here in terms of a data framework. Understanding the consent that's in place for that data that can be part of the framework, and make sure you're complying with those requirements according to legislation. And then having some sort of system to enable access in a more automated fashion would be really helpful as well. So all of this, we're really saying, is the governance aspect of being able to get access to data and to then be able to start using the data. So BioGrid actually came into place about 15 years ago, or over 15 years ago now, to exactly address these questions and these issues. And BioGrid was created to enable clinical researchers in particular to be able to navigate the way through all of these issues and to accelerate that process for them so that they could just get on with the research. Get on with the research rather than having to deal with all of these issues over and over and over and over again. So what was created was an Evergreen legal agreement, and that is to facilitate multi-site collaborative research. So all of the members that we have as part of the BioGrid collaboration have all signed up to this collaboration agreement, and the University of Melbourne is one of those. And by Evergreen, we mean that it doesn't have an expiry date. So when you're normally doing research between several sites, multiple sites, usually you need to put in an agreement between those sites for that specific project. It has a start date and an end date. In this arrangement, we have a start date when the organisation joins, but there's no expiry date. It goes on forever. An organisation can come out of it quite straightforward if they wish to. So it's not prohibitive to do that, but it means that we don't have to keep signing the agreements all the time between these collaborating institutions. So we've really streamlined that process in terms of the legal compliance. And it's addressing all of those things that you would normally see in a multi-site agreement. What about the IP that you've got before you come to the doing a joint project? What about any IP that might come out of a collaborative project together? And they might be just a subset of those organisations, not everyone. What do you do, and how do you handle any commercialisation that comes out of a particular collaborative project? So it's dealing with all of those matters, which usually are what organisations are concerned about and why they want these legal agreements in place. That's all there. And then one of the other issues that's really important about having a framework that can work, that everyone is comfortable with, is to ensure that there's actually ethical approval for the platform itself. So this is not approval to access the data. That's separate. That's project ethics. This is just the ethics for the platform. So at every institution where we have data that's connected to the platform, we have ethical approval of how we manage data sharing. What's the consent model? All of these things, security, etc., they're all handled in a direct ethical approval at that institution for all of the data that is connected to the platform. And every time there's more data that's connected, it's an amendment to actually add to the existing ethical approval. This means that at the executive level of the organisation, they know and agree that this is going to happen and that they are part of this collaboration, and they're comfortable, they're signing up to that. So that's really important, but it serves as a good process to manage any future work as well. And finally, there is a way to manage this so that people are comfortable is through a federated platform for data sharing. So not this concept of bringing the data from different institutions into a big data lake or a big data warehouse and putting it all together, which would be great in one aspect, to be able to just, you know, modify it and work with it and have people can get access to it. No, enable people to still have control and being able to say yes or no how their data is used. Now, BioGrid has in place a waiver of consent or an opt-out consent for hospital-linked data across the country. This is because routine clinical data is being connected, and getting opt-in consent is not feasible or practical, and there are good reasons under the NHMRC to allow this kind of waiver, and so that's what we have. So this enables a lot of data to be linked to the platform and made available for research. So BioGrid is one of the key features of BioGrid is it's an independent entity. It's a not-for-profit organisation owned by its members. So the University of Melbourne, for example, and the various hospitals and many other members, they all are part owners of BioGrid. And that's because BioGrid is serving them. We are doing the things that they don't have to do because we're doing it for them. And by doing it as a centralised capability, then it's not getting duplicated and having to be, you know, spend cost and spend time and money doing it multiple times in other places. So we can do that on their behalf. And we're trusted because, sorry, I've just lost that one, it's gone off. The platform is trusted because we are independent of government and we are independent of industry and we're owned by the sector. So this is an overview of our current members. Now, La Trobe University is also a member, and they're not on this slide yet, but they'll be going on shortly. So there's a lot on there, but what you will see is that we have a lot of members in Victoria. That's kind of logical because we've started here in Victoria. This is where we're based. We've had a lot of, in the past, funding from the Victorian government. We don't get funded by government anymore, so there's a heavy presence in Victoria. But you can also see that we have memberships and collaborators in other parts of the country, and that's really really facilitates national work. And this means that it's much easier to then get another collaborator on board if there's particular national projects that demand that, because there's already an example of it happening in their own jurisdiction. The collaboration agreement we have in place also allows for project-specific collaborations. Now, this is very important because as academics, you'll also sometimes be working with organisations that might not be part of the BioGrid membership, and we can manage that. So what we do there is we have a project-specific agreement in place that's just specific for the project to allow these projects to occur. So it does mean that particular researchers who are part of the membership can still work with others, but we just put in a project-specific arrangement. We can also utilise the BioGrid Access Request System, which is an online system that has ethical oversight by Melbourne Health. We can utilise that process to be able to get the ethics for projects as well. And if there is specific projects that require support and work from BioGrid, then we obviously will cost that accordingly to the project. We also do work with industry. So industry doesn't get access to the raw record level data. They get aggregated summary reports based on a protocol. But by having these project specific arrangements, it does mean that we can do work with industry as well as other academic partners or other hospitals specific to an agreement in place. So it gives that flexibility to researchers to be able to work with many other partners if necessary. Coming back to the data sharing framework, that's all great to have all of this, governance in place, but what about technically how are you going to do this? How are you going to actually bring this data together? So in some form or another, you need some sort of technical framework for data sharing. As mentioned earlier, we have data in all sorts of places that don't have any mechanism to be able to connect that that's the same patient. Patient A in this data set is patient A over in this data set. How do you connect these and link these data sets? So having linkage keys to be able to match patients is pretty critical in a data platform. And the other thing too is that you want to ensure that only the correct people have access to the data they've been given approval to, and that they can only see that data. So how are you going to have a good system to authenticate that only the right people see the right data? And to have some sort of tools for interrogating and analysing the data. So we need some sort of technical, aspects to this data sharing framework. So BioGrid then talked with all of its prospective members at the time to try and come up with a solution that was going to be satisfactory and meet the needs of the organisations concerned. And what was put in place was a federated solution. And the reason for that is because it gives confidence. It gives confidence to those that are sharing their data that they still retain control over their data. So this means that the platform in this federated sharing manner, with all the data transfers and linkages, that they are performed over secure encrypted network connections. That's really important to give the confidence to those organisations that their data is going to be safe. What our platform also has in place is a couple of methodologies for actually generating unique record linkage keys. So in many instances, BioGrid can access personally identifying information to generate these unique record linkage keys, but there are some instances where we can't. And primary care is a good example of that. So the primary care data that we do have access to doesn't have any personal identifying information. It's utilising deterministic hashing. In the case, we actually are getting access to data sets that use Granite, and some of you will be familiar with that. It's a University of Melbourne product that enables record linkage, and it's a larger product than that, but BioGrid uses that particular aspect. So having several different methodologies to enable the linkage of data across data sets can be very, very valuable, and that's really proven its case here. And a really important part that's really made the BioGrid framework successful is that the data custodian retains full control over access to their data. And that when data is provided to researchers, it's only in a de-identified coded form, so that no person identifying information is made available to researchers. So I'll just take you through visually how we do this with, say, a standard hospital, for example. So we have a hospital that's the pink to the right, that's our collaborating institution. Once we have the legal in place and the ethics in place, because we need to have those in place, then we start working on the technical solution for that. So the source databases are identified, and that will be part of the ethics. Remember that we have that in the ethics. We list the data sets and those custodians in those ethics, and then we just keep amending by amendments as we add more and more. So once we identify those source databases, then we set up a local research repository. This can be on-premise or in cloud. It doesn't matter, whatever the hosting institution wants to do, because it's in their environment. You can see it's within their institution. We set up a process where we're copying from the source. So BioGrid never accesses the actual source data. That's really important for performance issues and also for any inappropriate access and use of the data. So it's copied onto an appropriate place within that collaborating institution. We have virtual private network connections which are in place between each institution, so they're all separate. These are encrypted pathways to enable the data to flow between the collaborating institution and BioGrid. And then once we have data that is copied to the local research repository. Then we go through a process of obtaining, if there is person identifying information. We just take those pieces of information, not all the health data, just the person identifying information. We bring it into BioGrid and we put it through our linkage key federation server to generate a unique key. And so we do that, and then we copy the unique key back onto the server where the health data is. And this then enables us to, for example, if the patient already exists because it's in another data set at another institution, then we know that because we've actually stored, we do store the person identifying information. We don't store any health information, but we do store this to enable us to keep ensuring that we can do correct matching of individuals. Once that's set up, then it means that any researchers that are wanting to access this data, they will query. We surface the data through SAS. Researchers don't have to use SAS to analyse their data, but that's how we surface the data to researchers. Once researchers have ethical approval for their project to access the data, then BioGrid will make it available. We make the data available in libraries that they can then get access to. And then what they're really doing is they're querying our federation server, which has the metadata that knows which institution, which data set, which data these approved researchers are allowed to have access to. And we've set that up in that library that they query. And so when they query that, they're actually going to this local research repository, and then it brings back to them the data in a coded, de-identified way that they can then have research to, have access to do their research. This is just another way of looking at this. So we have here 3 keys in red, and what that's really telling you is that before researchers can access data, they'll go through our online access request system and they'll select the data sets they want to have access to. They'll put the science of their project, what they're wanting to do, and then all the researchers they list on the project then need to agree to terms and conditions online. Now this is instead of, this is a streamlined part of the process. This is instead of researchers having to sign an access agreement, a data access agreement. Remember, we've got this overarching collaboration agreement that's already in place. So that's already there. These terms and conditions are just for the individual researchers that are employees or students or of those member institutions. And they're just having to agree to the things that matter to us about the data and how they're going to use it. You know, they've got to do the right thing. You know, don't store it on a USB stick and leave it in the back of the taxi, right? You've got to do the right thing with data. So it's really just getting them to sign up to that. So once they've all agreed, then it goes to the data custodian. So you can see here we've got the policeman with their hat on. This is the person who is the custodian of whatever the data sets that they have selected. So they get to see, it goes online, they get an email to get them to review this. They see who the researchers are and for what purpose they want to access their data. And they have the right to say yes or no. So if they say yes, fine. If they say no, sometimes it's because they don't have, they feel they don't have the actual data that this particular project is looking for. It sometimes generates discussion. It could be that sometimes they're working on similar projects, so it encourages collaboration. It's very rare for custodians to say no. All the data that's connected to BioGrid is voluntary. You know, it's not something that's mandated. So most people that are making their data available are collaborative folks and they want to make it available to others. So the custodians have to say yes before anyone has access to the data. And finally, the project must have ethical approval. Now, the researcher might have already obtained ethical approval. That's great. We just need to see that. If they haven't, they can use the BioGrid process to obtain it. And that's a really streamlined process because you don't have to complete a full ethics application for your study. Why? Remember, we have ethics approval for the platform already in place at every institution where there's data connected, so that the custodians and the institution know how the data is managed and know how that's going to be managed into the future for any researchers, and that we are ensuring as BioGrid that the researchers are doing the right thing. So it makes a streamlined process. It goes in as low risk to get its approval. So a very streamlined process, particularly for multi-site studies. So once all of those things are in place, then we have the green light, and then BioGrid can make those data available in a de-identified way. I'd just like to move on to a few case studies, this I'm just trying to have a look to see how I'm going for time. Okay, so with the case studies, I'd just like to quickly go through a few of these. So this is the Victorian Comprehensive Cancer Centre, their data-driven research hub. They're about to go into a phase 2 of funding. It's been going for about three and a bit years. And this is looking to really bring together a lot of data that's administrative, costings, as well as data to primary care, linking it to primary care, and to look at linking to the Victorian Cancer Registry, as well as other clinical registries. So a big program of work. And BioGrid is providing this. So the project leads are John Emery and Martin Iserman, and Chris Kearney is the program manager. And as you can see, we have 10 institutions that are part of this particular collaboration. And so part of the really significant streamlining here is that the 10 institutions that are part of the VCCC already were part of the BioGrid collaboration. We already had the agreement, the collaboration agreement for sharing data was already in place. So that meant from day one, we already had the legal in place. We already had the ethics in place, because these institutions all have ethical approval in place for the sharing of data. So we've got the legal and the ethical already done. That saves a huge amount of time and effort for a big program to get up and running. Then all we need to do is look at, well, what's the data? And then let's get working on the data, because there's a whole lot of new data to bring in. And that's got challenges. And we're really pleased to be working with the Centre for Digital Transformation of Health on looking at ways that we can actually get some common data models, looking at how we can improve the research readiness of data. But, there are significant, really significant hurdles that researchers face to get the legal and the ethics in place for big programs like this. So by having all of that in place already just meant that it could hit the ground running. This program is looking at data across the whole spectrum of general practice, primary care, and the hospital setting, and then back into primary care again. And that's a really important part of looking at things like delays to diagnosis, sort of treatment outcomes, etc. This is kind of where we're up to at the moment. So phase 1 is just finishing now, and phase 2 is where we're going into. So the primary care data sets that we've been working with so far is NPS. BioGrid has a cut of the Victorian NPS data set, but now it's just been approved just recently as to access the Patreon data set as well at the university. So now we're starting to look at phase 2 in terms of the next a lot of funding to really look at significantly adding quite a lot of other data sets as well. This is just a very brief overview of some of the data that's available at the moment in terms of the fullness of data and the sort of numbers that we're looking at. And there's now some research starting to happen at looking at what's happening in terms of these particular patients, where there's anything in the information in the primary care data that's giving any indication of cancer symptoms, so that you can get a feel for how long is it between when they're starting to get these symptoms to when they actually got diagnosed and then might have had treatment. And this is just starting to break it down in terms of the tumour stream. So this is the work that the VCCC is doing now that they've got access to these data. And this is really going to inform some significant pieces of work over the next few years in the next stage of funding. I just wanted to throw this one in because it does underline some of the challenges that researchers face. So this is a case study on Cushing's disease. It's a disease that doesn't affect many people, so there's small numbers. And what this project wanted to do was to actually just access hospital data from every state and territory. So they weren't wanting to link their data to the hospital data. They just wanted access to the hospital admissions data for patients who've had surgery that would be relevant to this particular condition. Now, one of the challenges that you face, and this we applied through the PHRN because that's how you access this other hospital data. One of the challenges that researchers face is this. So here we have, these are the steps that people need to go through before you would get access to the data. You can see all these things here. I'm not going to go through them in detail, but I get that the point here is that every jurisdiction has a different process. Not one of those states or territories has exactly the same process. Plus, their forms are all different. So this is challenging and time consuming for researchers. By the way, just so that everyone knows, this is the process for BioGrid. So if you do have linkage work that you need to have done, or you need to put some funding in your grant, for example, we can tell you up front, not down the track after you've done all this work to try and find out. That's really important for researchers. So I just thought I'd show you that navigating these things and getting access to data is challenging, and this is the kind of service that BioGrid can provide. This particular case study is in rare cancers. It's the Australian Genomic Cancer Medicine Centre, and there's a rare cancer portal that BioGrid's supporting. This is really to support regional and rural doctors, and what we're doing is developing a portal that enables data to be, for doctors to refer patients, to be able to get access to the best information and treatment that's being advised by this portal. And then relevant patients will be put into genomic trials as well. So this particular program, we're doing quite a lot of work for and enabling the record linkage between various data sets as well. And this just gives a little bit of an idea where we're dealing with specific databases, REDCap as well. There's a number of sites around the country that will be part of this, that will be helping to refer patients. And this program is well underway now. Okay, so I just want to finish off on BioGrid's core capabilities and services, just to emphasise how we can accelerate research. So that data governance, privacy and security, these are aspects that we have a lot of experience in with all jurisdictions, and we can really streamline the process for researchers in this aspect. In terms of data linkage, integration and interoperability, that's also a key part of what we do when we're linking the data and then making data available across jurisdictions and data sets for researchers. If researchers need this service, we can also provide data insights from analysis and reporting. And we also do bespoke data collection software for clinical and research use. There's a number of registries, particularly cancer registries, that we've developed over the years. And we also do REDCap software configuration for research use as well. So I think I better finish up there and see if there's any questions.
Thanks, Maureen. Thanks for your clear explanations and for sharing expertise on data frameworks and processes in BioGrid's work. Does anyone have any questions? So feel free to either type your questions in the chat or unmute yourself.
I've got a question that's not very well formulated because I'm trying to absorb what you're saying, Maureen. It's Natalie Thorne here from Melbourne Genomics.
Oh, hi, Natalie.
How are you?
Well, thanks.
That was a great talk. I really enjoyed that, and I was frantically taking notes because lots of things that you said really good to revisit in terms of some of the things that we're thinking about in Melbourne Genomics and indeed in Australian Genomics around sharing genomic data. There's a few things I picked up on that you don't, you store the personal information, like the patient identifying information, so you can do all the matching, which we of course don't do in Melbourne Genomics for the purposes of all the clinical data. But I was just, the Global Alliance conference has just been happening the last couple of days. I don't know whether you've been participating in any of that, but there's been a lot of discussions about passports and the ability for researchers or clinical researchers to get a passport with visas in it, and then to be able to use that to search data across places, you know, across states, countries, you know, across borders essentially. I just was interested in your perspective, whether you've got any perspective, at least at the moment, about the concept of that, and given your experience and how difficult it is to share data, you know, what do you think of is the feasibility of that approach, and what are some of the challenges that the genomics community is going to come up against?
Yeah, it's a good thing to bring up, Nat. Look, I think that the biggest challenge, I think that the technology and the concept is quite good, but it's the issue is going to be the implementation of it, and more importantly, organisations or data custodians feeling comfortable with the concept, and then you've got the implementation, you know, aspect as well. So I think, unfortunately, you know, anything to do with health data, and I think genomic data has a little bit more sensitivity around it as well, given that, you know, the whole genome is unique in its own right. That really, I think it's going to come down to people's attitudes, perceptions, and acceptance of these types of things. It's taken a long time for the health sector to sort of become comfortable to do some of the things that have been happening in other sectors for a long, long time. And I suspect that this may also take that same route. But on the other hand, if we can get a few people to sort of champion it and see that it's, you know, the sky doesn't fall in and that it's actually quite a good thing, then perhaps we can get some people supportive of you know, such a process and technology.
There's a few questions on the chat. The first is there a public participation component on BioGrid? Cecily was wondering if patient or consumer views are embedded.
So BioGrid does do some work with consumers. We're working at the moment to actually include consumers within our governance framework, you know, in terms of committees and things. So we're actively pursuing that at the moment. BioGrid does support some actual systems that collect data from patients. So this is patient-driven research where patients are providing their data to be made available for research, and that's a consented model, by the way. So we do work with consumers. We have the capacity to do that. As far as the data that's generally made available through a lot through hospitals and obviously other research networks, some of those data sets will be consented because of the type of studies that people are doing, but as I mentioned earlier, most of it's not. So if individuals feel that they don't want to have their data available for research or linkage or to BioGrid, then we can remove them from being available, and also that can happen at the source. So if they tell their clinicians or their hospital that they don't want to be, then that can happen. But as far as consumers being involved in BioGrid, as I said, we're working on getting them involved in the governance model. Several of the groups that we do a lot of work for, so like the VCCC and the AGCMC, etc., they have consumers as part of the program. So they are definitely involved and participate and provide their views on what's happening in terms of all the programs of work, including the data linkage.
Thanks, Maureen. The next question is, do you host data beyond tabular data, such as images?
Yeah, that's a great question. So yes, we do have some, and the major issue that we've had to date is because we have most of this would come from hospitals, is the internet incapability, I should say. So what researchers really want to do, of course, is to be able to have, the annotated data that they have access to, which is more what the tabular data is talking about, as in addition to the imaging. And to access the imaging, via the internet is under the current hospital systems that are available is just not feasible. So we have images linked. We have done this work in the past, but making it freely available through the hospital internet network. And we sort of need to work with the lowest common denominator. Whoever is the hospital that has the lowest means it's going to be the problem for everybody else. What will be good is if the hospitals in Australia had access to the RRNet capability that the universities have with the big pipes, which enable this kind of data to be shared. I think there's a few hospitals that are starting to get onto that system, but until all hospitals are on such a system, this problem will remain. However, BioGrid is currently now doing some work to uplift some of its infrastructure with doing some transition to cloud, but also to look at having a really streamlined, secure research environment. And should that happen, we can then at least place, with the permission of the various institutions, we could host, for the purpose of linkage, these images in a different setting, which makes it much more accessible.
Thanks. The next question is, could you please explain the consent framework BioGrid is using?
Okay, so as I mentioned earlier, most of the data that's connected to BioGrid is collected during routine clinical care, where opt-in consent is not usually provided for any purpose. BioGrid, Australia, if you look at the privacy arrangements in Australia, they actually operate under an implied consent model. Now that actually causes some challenges for anyone wishing to comply with the GDPR, for example, in overseas. Because the Australian privacy model is implied consent, then that allows us in Australia to then say that, well, people are implying their consent by, for example, if they're meeting with one physician and the physician then needs to talk to another physician, you don't have to seek approval or consent from the patient to then talk to another physician about your condition. Now, I know that's different to research, but I'm just saying that is what the implied consent model is really explaining, that it's an implied consent to be able to give the best care possible to an individual. The waiver of consent is in place, and that's allowable under the Privacy Act and also the NHMRC guidelines for research for the purpose of doing research. And often this is because not to have bias in the research, to ensure that you're getting all patients rather than just those that might consent in. Because if you're looking at a lot of data across a particular condition, if you start to look at trying to introduce opt-in only for routine clinical care, and it's been proven, on many occasions, you just cannot get the take-up because of the way the clinic structure is working. There's not the time to be able to consent everybody actively when you're seeing patients. And so therefore you end up with bias in your cohorts for research.
Thanks. There's one more question. Are there excess costs that relate to specific projects, or are they covered by the participating institutes?
Sorry, could you say the first part of the question again?
Are there costs associated with access?
So BioGrid's business model is that we have member subscriptions paid by institutions. Those are not exorbitant by any means. We also have fee-for-service work that we do. So people that obviously have grants and other things, and we also do some work for industry, as I explained before. We have just recently introduced what we call research user fees. These are very these are very affordable as well. For example, it's bronze, silver and gold. So the bronze is $3,000 a year plus GST, and that allows up to 20 hours of our support for over that year. And then, you know, you go to silver and gold. And that just ensures that all of this type of support work that we do provide, that we can, you know, get that covered in the costs. But it does provide, you know, a lot of support to researchers in what they're doing.
Thanks, Maureen. Does anyone have any last questions?
Maureen, it's Natalie again.
Yeah.
How much experience does BioGrid have with trying to get data out of EMRs?
Great question. So we've just been working over the last few months with the Parkville precinct with Epic, and we've been intimately involved with two departments. So BioGrid historically has been providing clinical systems for dermatology and endocrinology. So this was in the absence of a medical record, you know, an electronic medical record. It was pulling in pathology from the pathology system, demographics from the patient management system, etc. And then they would use these systems to collect their data electronically instead of, you know, doing the paper forms. So it was their form of their electronic medical record. So of course, when the whole hospital was moving to an electronic medical record, they wanted to ensure that they could keep capturing the relevant data. But of course, they had years and years of historic data in the other data set. So we were able to work with the Epic team here in Melbourne to work on, first of all, ensuring, in agreement with the clinicians and the Epic team, that they could capture all the data that was required. And then secondly, to work out a process about how we could get the data out of Epic and back into those systems that they could continue to use them for research. Some of these groups also report into national registries, which we facilitate. In fact, in one case, we host the national registry. It's the Australian Psoriasis Registry. So to enable that to happen, you know, it was important that we could actually keep getting data out of Epic. So we're just doing some final testing before going to production, actually, at the moment, of being able to do that. So we've been able to get the data out of Epic for both of those systems, and it's quite comprehensive, the data that we're getting, to bring it back into a staging area, to pick it up and then to put it into that existing database. Now that could be, it might be that that people don't have an existing database. It might be, you know, we just configure REDCap to be able to capture what they might want to use out of Epic. Or any other, you know, electronic medical record system. But that's kind of a long answer, but the short answer is yes.
Thanks, Maureen. Thanks for your time today, for sharing your insights with us. Just wanted to mention that our next seminar will be in the next fortnight on the 15th of October, Thursday at noon. We have Associate Professor Adela Grendo from Arizona State University who will be discussing patient views on data privacy with us. Well, thank you everyone for joining in, and have a great afternoon.
Thank you.